Greetings, everyone, and welcome to our lesson on intracranial hemorrhage. Specifically, we're going to discuss the differences in presentation and treatment in the emergency department for subdural and epidural bleeds. So the definitive treatment for these injuries is significantly different, and that being the case, it's very important to recognize some of the telling signs and symptoms that are going to help us decide which injury our patient sustained. So when it comes to presentation, there are some subtle differences between the two, and there are really some glaring differences. So let's go through them, and we'll start with subdurals. With a subdural bleed, our patient is most likely going to have a headache. This can be as simple as kind of like that annoying headache that we all get, or one that's causing them like severe pain. And what we want to know is how long has this been going on? The concept of the acute versus chronic bleed comes into play with subdurals, and you can read much more about that in our neuro lessons throughout nrsng.com. They're going to have a slow and progressive loss of consciousness. They may complain of being overly tired, a little more so than usual. The pupils are going to be fixed and dilated. First, you're going to have one. That's a terrible diagram. I apologize. And then you're going to have both. That's fixed and dilated pupils. I really should take an art class. Anyway, the respirations are going to be abnormal. They can be hypo or hyperventilating, either one. They're going to have contralateral hemiparesis or hemiplegia, and that is weakness on one side of the body. An interesting thing about that is we all know left side controls right side. So if they have the hemiparesis on I guess this would be the left side of the body, you can assume that the injury is on the right side of the brain. I realize I really got to work on the drawing, guys. I apologize. But that's contralateral hemiparesis, hemiplegia. It's paralysis or weakness. And most likely, these patients are going to have an increase in their intracranial pressure. And many times because of that, they're going to experience nausea and vomiting. With our epidural bleeds, the headache is going to be severe. Now, some people have reported like feeling like a gunshot went off in their brain, or like they got stabbed in the head with an ice pick, which you can imagine probably not the best feeling in the world. Because of that, they're going to be agitated, and they can have a sudden or progressive loss of consciousness. I talk about lights out, lights on, lights out, and this is really like a super telltale textbook sign of an epidural bleed, guys. You're going to see this. I mean, if you haven't graduated nursing school yet, this is like NCLEX type question. And what it means is that epidurals are usually sustained from a traumatic event, and the patient will have kind of an instant loss of consciousness. They get hit, they get knocked out. That is followed soon by a period of awakened lucidity. Basically, they got knocked out, they wake up. Then it's followed by another loss of consciousness, and when that second loss of consciousness happens, you got a problem. If this is reported to you, this should send up a ton of red flags, guys. This is a bad sign, and usually very indicative of an epidural. The pupils here will be unilaterally dilated. I'm going to give it one more shot to draw some pupils. So we have our two eyes, and we are unilaterally dilated. All right, that wasn't bad. That really didn't look right, but you guys know what it means. So we have basically unilateral dilation, bad sign of a head injury. Again, we have that one-sided weakness. And when it comes to the vital signs, usually we're going to see bradycardia, hypertension, and again, the abnormal respirations, and whether those are hyper or hypoventilating, it can be either. So when we're assessing our patients, many of the assessments are the same for all of our ED patients. But with these patients, we really focus on the disability. We want to do those serial neuro exams. Probably every 5 to 15 minutes, I would check with your facility's policy. And what we're looking for is the Glasgow Coma Scale. And remember, guys, that is motor response, eye-opening, and verbal response. And the scale goes from 3 to 15, not 0 to 15. That's a no. 3 to 15. Okay? Again, I've said this before. I'll say it again. The computer screen you're watching this on has a GCS score of 3. So make sure you document those GCSs right. As with any of our patients, we want to monitor the airway, breathing, and circulation. And if our patients have a Glasgow Coma Scale of 8 or less and a funky CT scan, we're probably going to monitor their intracranial pressure with an ICP monitor, most likely inserted right in the ED by our wonderful neurosurgical team. Therapeutic management. So we gotta manage these guys, right? I mean, they're gonna be in our care for a little while. Well, if the GCS is less than 8, it's usually assumed that they're probably not protecting their airway. So less than 8, probably going to intubate and ventilate them. With that, we want to keep that oxygen level above 95% to make sure that the brain is perfusing and we're getting the oxygen where it needs to be. Now, be careful to avoid hyperventilation. Now, I know you're thinking, why would that be bad to give them more oxygen, Nurse Mike? You just told us the brain needs oxygen. Well, I'm glad you asked. So while oxygen is, of course, vitally important to brain health, hyperventilation can actually cause an increase in intracranial pressure. So we really want to be careful with that. Don't overbag them, guys. And I've seen it before. I've seen the nervous new nurse just kind of pumping away at that BVM at 40 breaths a minute. Way too much. Be very careful. Keep an eye on that O2 sat. We're going to restore the fluid volume as needed. The way we monitor that, throw that Foley cath in, throw that urinary catheter in, and keep an eye on the output. And what we want is that 0.5 to 1 milliliters per kilogram every hour. And we're going to titrate our fluid boluses to that. We're going to keep an eye on that. Depends on how much we're getting out or not getting out. We'll adjust our fluids. If we have a patient with a GCS of less than 8 who's intubated and has that ICP monitor, we, of course, will want to reduce the intracranial pressure if needed. Now, we can do that with medications like mannitol. We've all seen that. That's the osmotic diuretic. But we can also do it through physical interventions, just like positioning or decreasing the stimulus. What we use is really going to depend on the situation and their actual intracranial pressure level. So with subdural bleeds, we have to act, but we can really be a little more meticulous with what we do. These patients are going to take a nice, easy ride to the OR. We'll replace some small burr holes, and burr holes are literally holes drilled into the skull, and that's going to allow for some gradual drainage of the fluid building up. Now, honestly, my hope is that most of us work in a facility that'll be a little more sterile than this situation here. But I do have to say, I love the hat the surgeon's wearing. I think that should be standard part of the uniform. I'm not quite sure what the nun is doing with the book here, but I can say that I've tried it in the OR once. It did not help the situation. Anyway, with our epidural bleeds, the patient will probably go an emergency craniotomy or a removal of a piece of the skull to allow for a rapid decrease in intracranial pressure. Now, you can see in the picture here, we have removed a flap of the skull, and we can see the brain. What that did is they remove that piece of skull, and instantly you're going to get that release of intracranial pressure. How long they leave that skull cap off is really up to the neurosurgeons. So I highly recommend you guys go and review your anatomy and physiology. Check the neuro lessons around nrsng.com to learn where and why subdural and epidural bleeds occur. As always, it's important to evaluate our patients' cognition throughout their stay in the ED. Don't forget about them. We're going to use our neuro exams and our Glasgow Coma Scale to keep an eye on their neurostatus. And if needed, we want to treat and watch that intracranial pressure and treat it accordingly. We want to keep that intracranial regulation where it should be. All right, guys, I want you to remember the signs and symptoms. What happened? Oh, there we go. I want you to remember the signs and symptoms for each and which are specific to the injuries. If we can get a good history, that's always going to help us towards a new diagnosis. We want to know if this is a sudden new issue or if Grandpa has kind of been getting more sleepy and more tired over the past couple of weeks. We want to make sure that we're always documenting our neurostatus, documenting our Glasgow Coma Scale. Remember 3 to 15, all 3 aspects, the motor, verbal, and eye-opening. We always, in these situations, we've got to be ready to assist our neurosurgeons should they need to intervene in the ED, whether it be burr holes, putting in a bolt to monitor. All of these things can be done in the ER, especially in our tertiary centers. And as always, we want you to keep an eye on that intracranial pressure. Now, they don't have to be monitored. We can pick up on changes in intracranial pressure just from what we see. So really, we have to keep a very close eye on these patients. Okay, guys, so that's a little bit about what we do for subdural and epidural bleeds in the emergency department. I hope you guys all join us for our next emergency topic. And as always, happy nursing!